all. I'd like to first just thank you all for the opportunity to be with you today and talk about an important topic, and also for you giving your time to this presentation so that we can sort of discuss these things together. So I appreciate, again, Glencore reaching out about this. I'm an adolescent medicine physician by training, and I currently work with patients at the University of Virginia's Teen and Young Adult Health Center, where I am fortunate enough to have a multidisciplinary team that helps me care for patients with eating disorders. And so the second part of this series is going to be done by Dr. Sarah Groff Stevens, who is a PhD social worker and helps to provide therapy in our clinic. And so again, my background is in pediatrics. I did my residency training here at the University of Virginia, did my training in adolescent medicine at the Indiana University Children's Hospital, Riley Children's Hospital, where they also had an eating disorder specialized center, the Caris Center. So I was able to be involved with care at the inpatient level on a med psych unit, as well as partial hospitalization, intensive outpatient, and outpatient care. And so providing care for patients with eating disorders is one of my passions. And so I'm going to talk to you today about how we identify and treat eating disorders and pay special attention to the data that we have about marginalized and overlooked populations. And so my objectives listed here are lofty, but I think that in our time together, we can touch on each of these and still have time for questions. And just if Glencore gets the chat open, I'm okay with questions going in the chat, but maybe it's safer for us to use the question and answer at the end, but I guess we'll address that as we get closer to the end of the presentation. So before we begin, I think it's important to acknowledge that there's a great deal of stigma and misunderstanding surrounding eating disorders. So a few things that eating disorders are not. It's never as simple as just you need to eat more or you need to eat less. It is not voluntary. And while eating disorders are common in adolescents and young adults, this does not mean that it's just a phase or that you cannot develop an eating disorder later on in life. Eating disorders are a result of a complex interplay of genetics and the environment and factors that are not completely understood by scientists. No research currently substantiates the claim that individuals with eating disorders are weaker or have a moral failing of any kind. Nor does research support the often portrayed skeletal, affluent Caucasian female as the typical or most common presentation of an eating disorder. And we should be quick to recognize that there is a multitude of experience that exists within the populations of individuals experiencing eating disorders. This wide variety of eating disorder experience also makes it more challenging to know for certain when a friend, a colleague, a family member, or a patient might be struggling with an eating disorder. But given how common eating disorders are among Americans, it is certainly likely that someone you know personally is currently now or will suffer from an eating disorder at some point in their life. And eating disorders, regardless of the body size or shape of the patient, are life-limiting and potentially fatal. They disrupt the quality of an individual's life and can lead to suicide, overdose, or death from medical complications. But they can be treated and life can improve for individuals struggling with eating disorders. But just as in other areas of healthcare, access to high-quality evidence-based care can be challenging. And those places and centers who do provide care for youth with eating disorders have been inundated and overwhelmed by the surge of new patients. This is a study that looked at over 5 million health records, showing that the incidence of eating disorders was 15% higher in 2020 compared with previous years, demonstrating a relative risk increase that marched steadily onwards to exceed 1.5 by the end of the year. And this increase was primarily in females and primarily related to anorexia nervosa. Many of these new patients have also been far sicker, requiring hospitalization for their eating disorder. You can see here a published study out of Boston Children's where they looked at the admission numbers, both pre and post-COVID, divided here by this dotted line. And they note both a general steady increase as well as a sharp spike in admissions in the fall of 2020. Similarly, in Australia, at Perth Children's Hospital, they noted an increase in admissions for anorexia nervosa specifically, highlighting that this was occurring at the same time that they saw a decrease in hospitalizations for all other causes, as evidenced by the blue line on your screen, across the children's hospital. And yes, here too, we saw a dramatic rise in our eating disorder admissions, which had remained fairly stable between 2019 and 2020. But the steepest part of this slope you can see was when the pandemic set in for our youth here in the state of Virginia. The pandemic has not been, however, the only factor in the increasing number of youth presenting with eating concerns or being referred for eating disorder evaluation. There is a growing recognition of the wide variety of eating disorder presentations and the ways that eating disorders may look similar or different in historically marginalized and overlooked populations. In a study of college-based eating disorder screening programs that used a combination of self-report questions as well as counselors' assessments of eating disorder behaviors in an ethnically diverse sample of over 5,000 students, they found no difference in eating disorder behaviors such as binging, purging, and restricting. And in another study, looking at the National Institute of Mental Health's Collaborative Psychiatric Epidemiologic Studies, which is a nationally representative sample of the US population, they found no difference in either 12-month or lifetime prevalence estimates for anorexia nervosa or binge eating disorder. And importantly, found that bulimia nervosa was more prevalent among Latinos and African Americans. So actually lots of similarities across racial and ethnic groups, but the difference may actually be in access to care. The same study also assessed mental health utilization and noted that white respondents with a history of eating disorders had a higher lifetime prevalence of mental health service utilization than all other groups. They also found that whites were more likely to have accessed mental health care in the past 12 months. In another large-scale survey study, the Healthy Bodies study that looked at over 1,700 graduate and undergraduate students, they found that both gender and socioeconomic background also factored into mental health utilization, finding that females were more likely to perceive a need for treatment, to receive a diagnosis, and to be treated for eating disorder symptoms. They similarly found that students from affluent backgrounds were also more likely to perceive a need and receive treatment than their non-affluent peers. And we know that gender differences in eating disorders have been long-standing. And in fact, most of our diagnostic criteria has been typically cis female-centric, but males remain at a higher risk of dying due to lack of diagnosis and lack of treatment for their illness. These numbers, however, may be changing as we recognize more types of eating disorders, such as avoidant restrictive food intake disorder, ARFID, which we will cover more later on in the talk, which actually may be more common in males. In at least one study coming out of a gastroenterology clinic, the majority of their patients with avoidant restrictive food intake disorder were male. And if we zoom out and include dangerous eating behaviors that may or may not qualify one for an eating disorder diagnosis, a study out of Australia showed that up to 30% of male teenagers reported body dissatisfaction and the utilization of unhealthy weight control behaviors, but that these behaviors may not be the same as females, so more focus on muscle building as opposed to weight loss. This is likely higher for sexual and gender minority youth as well, as studies comparing sexual minority youth find that they have an increased risk of developing binge eating disorders, specifically in gay and bisexual boys, as well as for sexual minority female, there's an increased risk of both binge eating and purging. And the data is still emerging about the risk for transgender youth who may engage in disordered eating as an attempt to avoid pubertal progression or modify their bodies by changing the way they eat. but they definitely show higher rates of eating disorder symptoms in both youth who identify as transgender, as well as college students who identify as transgender. And while this data supports an ever-broadening diagnostic criteria, our formula for diagnosing eating disorder changes very slowly. It was only in 2013 when the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5, actually added binge eating disorder and avoidant restrictive food intake disorder as official eating disorder diagnoses under the feeding and eating disorder category. Binge eating disorder is now defined as the recurrent experience of episodes of eating significantly more in a shorter time period than most people would eat under similar circumstances. And these episodes are accompanied by feelings of being out of control and marked distress. They also have to occur on average at least once a week over 3 months. Avoidant restrictive food intake disorder can be diagnosed if there's an eating or feeding disturbance that results in significant weight loss, nutritional deficiency, or reliance on supplements or a feeding tube and interferes in social functioning. This, however, cannot be due to the fact that food is not available or there is food insecurity. Importantly, the DSM-5 did remove the requirement that a patient with anorexia nervosa have amenorrhea or have skipped a period or menstrual cycle for 3 months in a row. This allows us to make earlier diagnoses and include the diagnosis for patients who are younger or older or patients on medications that might alter their menstrual cycle. The change in the bulimia nervosa criteria has also allowed the criteria to be applied earlier and to individuals engaging in binging and compensatory behaviors less often, since the requirement is now that it occurs once a week as opposed to twice a week. Importantly, also for both clinicians and for researchers in advancing the field of eating disorder treatment, the category of other specified feeding and eating disorders, or OSFED, also identify criteria specific for atypical anorexia nervosa, where the patient meets all of the criteria for anorexia except for the significant low weight, low frequency bulimia nervosa, as well as low frequency binge eating disorder. This allows for better characterization of the patient's illnesses rather than the previous catch-all category, EDNOS, or eating disorder not otherwise specified. The hope is that identifying individuals who may have lower frequency symptoms or have experienced a shorter duration of illness will improve linkage to care at an earlier time frame and hopefully improve outcomes. And so while the Diagnostic Statistics of Manual of Mental Health Disease, or the DSM-5, has broadened the range of eating disorders that can be diagnosed, as well as the range of individuals who meet criteria for diagnosis of an eating disorder, it still remains challenging to identify warning signs, especially in historically overlooked populations. And we really have yet to refine our screening tools to include questions that may be more specific to those marginalized populations. So while I have listed a number of warning signs here, you can see that they might not be applicable to all populations, specifically food insecure populations or differently abled populations. So our next step will really be for us to broaden the range of eating disorder behaviors that we identify in community samples that place individuals at risk or are early warning signs of the development of the eating disorders that are not so female and cis heterocentric. And it's important to expand our screening tools and early identification of individuals at risk for eating disorders, because what we know is that the earlier an individual is identified as having an eating disorder or being at risk for an eating disorder, and the earlier they enter care, the better outcomes we can expect. So while there are better research or better screening tools currently in development and undergoing research that improve our ability to detect eating disorders within sexual and gender minorities, male athletes, and other previously overlooked populations, the validated screening tools that we're left with right now are ones such as this eating disorder screening tool for primary care, where more than 2 positives indicate a concern for an eating disorder in an individual using the questions below. Are you satisfied with your eating patterns? Do you ever eat in secret? Does your weight affect the way you feel about yourself? Have any members of your family suffered with an eating disorder, or do you currently suffer? Have you ever suffered in the past with an eating disorder? While I find this screening tool can be helpful, I think that it often overlooks many of the presenting problems that individuals with eating disorders from historically marginalized groups and overlooked populations may be experiencing. And I think as we better identify individuals with eating disorders within those groups, we will also have to do a better job of providing access to care for marginalized populations, that at each level of care, we need to offer resources that are affirming of individuals' lived experiences of their ethnicity, their gender, their race, their sexuality, and are accessible to all people of all socioeconomic backgrounds. So we have work to do. In an ideal world, all of our patients would have access to the level of care that best suits their needs, and insurance would be willing to cover it. And while in some locations, there's a continuum of care ranging from inpatient stabilization all the way to residential, partial hospitalization, intensive outpatient, and outpatient care. In those cases, we can attempt to really keep the patient in the least restrictive setting as possible that meets their needs, given the severity of their illness. We wanted to highlight that here at UVA, we are only able to provide care at the far ends of the spectrum. So we are able to admit patients who are medically unstable for medical stabilization in our medical hospital, not our psychiatric hospital, because we don't have a psychiatric inpatient unit for youth. And then we can also offer outpatient treatment. And in the state of Virginia, we actually have limited options for these other intermediate levels of care that are spelled out in more detail on this slide. We do keep a list of other resources and programs, both regionally and nationally, but it's actually a full-time job to keep it updated. And it's also a full-time job to navigate the complexities of referring patients to these various levels of care, while keeping in mind insurance coverage, program-specific requirements about BMI or use of feeding tubes, as well as patient and family preferences to be close to home or to be in a gender-affirming inclusive space. And so I don't put these details up here, meaning for you to be able to read them all, but just to highlight that these are the ones that are available in Virginia between those 2 gray bars. And so we really are limited, and these are really focused on the programs that are available for youth. And so what we've found throughout the pandemic is that often our wait lists at these facilities are incredibly long. And so our patients remain in levels of care that are not ideal for them for long periods of time while they wait for access to the appropriate level of care. The good news is that if your patient qualifies for outpatient management, there are a number of excellent treatment options available. However, I'm going to focus on family-based treatment or family-supported treatment because it has the best evidence base for use in multiple types of eating disorders with youth. This is a manualized approach to care that involves the whole family. Currently, the outcomes that have been studied are mostly limited to shorter term remission, 6 to 12 months, which are primarily defined by weight gain and reduced eating disorder symptoms. However, one study comparing short-term FBT or family-based treatment to longer-term treatment found rates of remission, again defined by body weight and menstrual patterns, at 4 years to be greater than 89% or better for both groups, suggesting that long-term remission is improved by family-based treatment of any length. Importantly, family-based treatment has also been adapted to settings where a teen does not have access to a certified FBT therapist, in which case we call it family-supported therapy, and it's modified just a bit, or for use with multiple families receiving care at the same time. In fact, there's a study out of Chicago right now that if families are interested in this multifamily model, they can join the study and receive treatment free of charge. It has also been adapted for use with bulimia nervosa, atypical or prodromal anorexia nervosa, pediatric obesity, and avoidant restrictive food intake disorder. And all of these adapted approaches, or what I call family-supported therapies, as opposed to the true family-based treatment, there is a somewhat more flexibility in the approach, allowing for a shift in focus to address comorbid illnesses or behavioral problems that may present themselves more often than is usually the case in the treatment of anorexia nervosa alone. There is even preliminary evidence to suggest that family-based treatment is effective for older populations in addition to adolescents. In a small study of patients between the ages of 18 to 26 who were willing to participate in a 6-month trial of family-based treatment, they showed that there was improvement in weight and reduced eating disorder symptomatology at both 6 and 12 months, although they did note a dropout rate of about 41%. And that's our experience with a lot of young adults, that the ambivalence towards treatment and recovery makes it challenging to have a prolonged period of treatment. So there are a couple of key principles to family-based treatment that I think it's important for us all to know, because they're being incorporated more and more to all levels of treatment and just the way we understand eating disorders and family units in general. Long gone is the notion that families are the root cause of eating disorders, or that some sort of family pathology is at the core of eating disorders. So one of the key principles of family-based treatment is separating the eating disorder pathology from the adolescent or the youth suffering from the illness. In this way, the illness is seen as an external force that has taken control over the child and is attacking their health. This allows parents and providers to join forces, and even the patient to join forces with the healthy part of themselves and the teen to fight off the eating disorder. So oftentimes I tell patients it'll seem a little crazy that I'm talking about ED or the eating disorder or the dragon or whatever they want to talk about it, the devil on their shoulder, in those terms. But the more that we do it as providers, the less crazy it seems to the adolescent. And then they recognize that that is something that they can externalize and they can use tools to fight against it. Additionally, family-based treatment remains agnostic on the cause of the illness, meaning we do not waste time trying to analyze why the eating disorder developed, especially in early phases of the treatment. There's also no blame, so we ask parents not to blame themselves or each other, not to blame grandparents or a comment by a neighbor, or blame their child for the illness. Parents also are empowered in this mode of treatment to provide full nutrition by taking charge of meals for their child. They again join forces with their team to provide adequate nutrition. And the treatment progresses through 3 phases that prioritizes initially the return to normal eating habits and expressly values adequate nutrition as a key foundation for the rest of the recovery process. So if weight gain is needed, the goal is to gain about 1 to 2 pounds per week in the initial phase, and parents help their teens to both eat adequately and to incorporate foods that they have been avoiding. If it's not anorexia nervosa and it's bulimia nervosa, it's eating at more regular intervals and consuming regular portion sizes. In phase 2, there's a gradual return of control to the adolescent. This phase usually begins once most weight has been restored and when meals are going more smoothly and when eating disorder behaviors are mostly under control. The teen is then gradually given more independence that is age appropriate over their own eating. So if they're in middle school and it's typical for them to pack their own lunch, they do that with parents just checking in to make sure they're providing their body with adequate nutrition. But parents may still remain in charge of dinner as that is age appropriate, whereas a college student may need to provide all of their meals themselves. The final phase is reestablishing autonomy and returning to a healthy self. So once the adolescent or the young person has resumed an age-appropriate level of independence and no longer is exhibiting eating disorder behavior, the focus of treatment shifts to helping them develop a healthy, balanced life and identity and to catch up on other developmental issues. I often tell patients and parents to feel grateful because this is the time when they get to fight over things like curfew and driving privileges as is more age appropriate. And I think it would be remiss if we did not acknowledge that exploring our own weight bias is important for all healthcare workers who may care for or come into contact with patients with eating disorders. And so in the words of Dr. Peebles, an eating disorder expert at CHOP, we cannot fear what anorexia fears and still help our patients. And we cannot fear getting to a higher weight if we want to have our patients fight these same fears. What we want is for our patients to be able to eat freely and flexibly in many different situations and have a body and brain that works and are not consumed by the eating disorder. Whatever body that happens in is great. And so we can be thoughtful about our own implicit biases about weight and size and shape. If you haven't had the opportunity to take any of the implicit bias tests, they're all fabulous for revealing your own sort of internal workings. They're free, and I think they're quite revealing. So my own test, the first time I took it, showed that I had a slight bias towards thinness. And this is well documented in the general population. And so it's impossible that those of us who provide eating disorder care are immune to that. In fact, in the general population, you can see here that 31% of people had a strong automatic preference for thin people compared to fat people. And now when I just retook it after being very conscious of my own biases and sort of adjusting to what we use in terms of a health at any size approach with our eating disorder population, I have now have the limited to no automatic preference between fat people and thin people, which again, I think took a lot of actual identifying what my own bias was and taking the time to figure out and look at resources to help me overcome that bias. And again, there is evidence that the bias impacts clinicians caring for patients with eating disorders, resulting in anticipating lower expected weight ranges due to a preference for thinness and a fear of larger bodies. It's also important to understand that weight stigma and discrimination or stereotyping based on a patient's weight can occur. And so maybe a reason that patients who live in larger bodies are reluctant to seek care. And that this may impact our patients as well as ourselves as we move throughout our days. And so a movement that celebrates diversity of human bodies is the Health at Every Size movement. And so this is actually a framework for compassionately striving for health improvements through movement and gentle nutrition without a focus on external indicators, most importantly, not focusing on weight. And so the Association of Size Diversity and Health asserts that one approach that can be incorporated everywhere and help in both the treatment and prevention of eating disorders is this health at every size. What I like about these principles is that they can certainly apply to helping patients who are struggling with eating disorders, but they apply in all care settings. And so thinking about how eating is a decision that does not need to be regulated by external cues, such as weight gains, but rather on internal cues, pleasure, and identifying that those two have a role in how we think about nutrition and eating for health. It also supports physical activities that allow people of all sizes and abilities and interests to engage in those types of movements. So again, I think this is important. And in addition to using it in the care that I provide to patients with eating disorders, I've incorporated it into my just general practice. So if we're talking about management of type 2 diabetes or high blood pressure or dyslipidemia, we can talk about it without focusing on weight, which I think again is helpful in reducing weight bias and weight stigma in clinical settings. And so I think I've left us plenty of time for questions because I think this is an important topic and I'd love to hear experiences from the perspective of those attending this webinar. But in summary, we as a society have placed values on food and ways of eating and certain body types and even exercise that are reflected in the myths that we must continue to work towards to dispel about eating disorders. And so while we recognize the variety of eating disorder presentations and how they may vary for historically marginalized and overlooked populations, we do this so that we can reduce the morbidity and mortality associated with eating disorders and ensure better access to quality care. Because our hope is that for each patient, they can have access to timely, supportive, and affirming care that allows them to fully recover from their illness. And so with that, I will stop share and I will try to look in the chat to see just who I've been chatting with the whole time. And then we can sort of open things up for questions.
Wonderful. Thank you, Dr. Taylor. I will help you navigate the Q&A here. We do have an initial question, and that is asking, how much do you think social media plays in this?
It's a great question. I think that is going to be one of those things that we identify as we look retrospectively at the pandemic. So the hypotheses around why we've seen such an explosion of eating disorders during the pandemic is that there was a lot of sort of unmonitored screen time among youth. That's only one piece of it, but that's certainly a huge piece of it. What we know is that it is extremely dangerous for youth to engage with what's called thinspiration or fitspiration. So these are not sites that are explicitly pro-anorexia, pro-ANA, or pro-bulimia, or pro-MIA, which are incredibly harmful and are typically run by people who have no interest in eating disorder recovery. But fitspiration and thinspiration are maybe just shy of that, right? And so it may just be pictures of, this is my workout on any given day, this is how many calories I consume, this is what I eat. And a lot of people will be attracted to that information. Adolescents, while I believe are capable of making good decisions, also are at risk of being influenced by that and failing to see the difference between a 25-year-old bodybuilder and what they're consuming and doing on a daily basis and what a 15-year-old can do and physically is able to do without pushing their body past the breaking point in terms of exercise or dramatically impacting their nutrition and their growth and development. So I think it's really important to think about monitoring social media use if you have a young person who you think is at risk. I actually ask families and young people to promise together that they'll monitor that and block sites that they both feel are harmful. Because again, I think adolescents can identify when social media is hurting more than it's helping.
Thank you for answering that. I do have a question here that came in through the chat, but as a reminder for everybody else to use the Q&A function on Zoom. And that is, what would it look like if we incorporated some of these phases with clients that are already enrolled in our DBT groups?
That's a great question. I don't think that there's any reason not to use them. So again, the principles and the phases are my adaptation. So I am not a certified family-based treatment therapist. I'm not a therapist at all, in fact, but I think these principles are hugely helpful. And so if the DBT group is primarily one of youth, then I wonder if it would be focusing on more that externalization of the eating disorder as something that the teen can regain control over by directly not avoiding situations where eating is hard or avoiding foods that are hard, but by putting themselves in a situation and using their DBT skills to tolerate that distress, right? So I think there are definitely ways to incorporate it. And I think what you'll find is that these principles and these phases from FBT have a way of sort of like working their way into all of our work with teens with sort of risky eating behaviors.
Excellent. We have another question here that says, for those in the training that work in an environment that is not specific to eating disorders, do you have any advice on how to bring up the conversation of eating or concerns about eating patterns in a way that reduces the risk of youth experiencing it as shaming / blaming, or reduces the likelihood of defensive responses?
That's a great question. I think it's always challenging. I think I have a couple of thoughts about that. So let me work through them in order. So first, I think that anytime anyone's concerned, it's appropriate to bring it up with the individual. And if you get a defensive response and you're still really concerned, to bring it up with one of their loved ones, like a parent or a guardian. It is not uncommon for us to get the final sort of rundown is that a teacher was concerned, or a counselor was concerned, or a friend was concerned, and that's what ended up patients seeking care. Um, I think NEDA actually has a pretty good toolkit for like how to have these conversations and how to approach it. And the basic steps are really focusing on the facts, right? So this is what I've observed, or this is what concerns me about these patterns and behaviors, and again, like you said, you can make it in a non-judgmental and non-stigmatizing way. What I've noticed is that it looks like it's been hard for you to eat recently. What I've been seeing is that your lunch is coming home and you haven't eaten any of it. Or what I've noticed is that there's a lot of food that goes missing from the pantry. And I just want to have a conversation about that because I worry about you not getting enough to eat earlier in the day. So again, I think there's a lot of ways to bring it up. And I think the importance is addressing it sort of head on with fact, because isolation, shame, and secrecy perpetuate eating disorders. And so while you can't guarantee you won't get a defensive response from parents or from children, I do think it's really important to address it with like, I have noticed, I am worried. And I think those are the most helpful ways to do that.
Wonderful. Thanks for that response. I put that in the chat for everyone just as a reference. She said NEDA has a toolkit. That's National Eating Disorders Association. The next question we have here is, what about treatment for individuals also diagnosed with serious mental illness, i.e. bipolar, schizophrenia, on medications that may increase appetite, impact lab work, etc.? How can they be supported/treated?
So there are some ways that we're learning about how we can better manage co-occurring illness. I think for too long, we've had this understanding that there's one and then the next and the next, and we could potentially like address them in a sequential manner. But I think for those of us living this as clinicians and providers, that just is impossible. And so I think it is probably important to be aware of those types of sort of like atypical antipsychotics that may impact appetite and weight. And I think that, again, the number of programs that can do co-occurring illnesses, whether it's substance use, whether it's autism, right? Because we see a lot of avoidant restrictive food intake disorder in autism. Schizophrenia is, I think, a tougher one, maybe because I'm not as used to seeing the diagnosis because people typically present a little bit older than my population. So I don't, like off the top of my head, I can't think of a single program that would identify schizophrenia as co-occurring with an eating disorder as their expertise. There's lots for OCD and things like that. And so again, trauma is a big one, right? So again, there's a couple of new modalities for addressing eating disorder and trauma together, as opposed to like as a sequential sort of understanding of those diseases. When we have patients who are discharged from like an inpatient unit or a residential unit and are on atypical antipsychotics, we do talk about how their hunger and fullness scale may not be something that we can rely on. That's true for severely malnourished patients as well. So I think having some understanding of how you're going to alter sort of what the nutrition plan is for a patient, depending upon how medications impact, again, their ability to rely on internal cues is going to be important. We have some patients where we say the goal is to get to intuitive eating, and we want you to be able to just sort of regulate your own eating, eat with a lot of flexibility. We recognize that sometimes co-occurring illnesses such as autism or medications may impact someone's ability to use those cues. So again, in people with neurodiversity, we don't think they get those cues the same way. They can, get wrapped up in something that they're really interested in and miss several meals in a row. And so for those individuals, we alter how we make our nutrition plan. So we say, Even though like we like the idea of you eating when you're hungry, we know that your body's going to need food at these intervals. And I think that it would be sort of similar but different if you had someone whose appetite was being stimulated by medications. We know that you're feeling hungry. We really want you to try to focus on these foods when you're feeling hungry, because we know that they'll allow you to feel satiated and may allow you to feel pleasure when eating, but they also won't contribute to sort of that metabolic derangement that we can see. Boy, that was a long answer. Sorry for that.
It was long, but it was helpful. It was certainly helpful. I hadn't considered kind of the connection between autism, understanding kind of the social cues and consumption of food. So
Yeah.
thanks for that. And I'm going to skip to this question just because it overlaps a lot with your previous question and response. Is this person asked about the link between ACEs, so adverse childhood experiences, and eating disorders. What is that link? And is there one?
I'm certain there will be one, but we don't have that data yet. I think in terms of following ACEs through to their outcomes, I think that eating disorders may have been overlooked in a lot of those. Again, thinking that our previous sort of thinking about eating disorders, that it only occurs in affluent, populations or abled populations or hetero populations. I don't think we have done the exploration needed to make sure that we also understand the connection between individuals who have experienced food insecurity or trauma during their youth or ACEs. And so I don't know that we have that information. I'm sure there will be a connection though.
I hope somebody here does that research themselves. Our next question we have is regarding to with the increased need during the pandemic, but long wait list, how can a clinician determine if they are equipped to support this population if they do not have an extensive amount of background / education? And how do you identify when to refer out, especially knowing resources are limited? Did you get that two-part question there?
Yeah, I think I can answer the first question easier. And that is like, if you are uncertain about the patient's trajectory with regards to their illness, either because it's not an area of expertise or you're doing it over telehealth, right? Like I can't tell if a patient's lost weight or become bradycardic when I'm doing telehealth visits, then ask them to follow up with their primary care provider for a set of vitals. Because again, growth is what we expect during adolescence, right? And so if a patient has failed to grow at a follow-up appointment, or if their weight has escalated beyond a sort of reasonable and expected, then you can consider binge eating, right? So vital sign visits and a check-in with a primary care provider are essential if you think you're dealing with an eating disorder, or if you think an eating disorder is escalating such that a patient may need specialized care. And the second piece is refer early, because in the pandemic, what we got were kiddos who had not sought care for so long, and they were just sick as stink. And so as we sort of slowly emerge from the pandemic, my favorite thing is to connect with a patient who may just be prodromal, right? Like may have a lot of risk factors for an eating disorder, may not meet full diagnostic criteria, but darn it, those are a lot better than hospitalizing a patient on their initial encounter. So I would say that that's what we do too when we're referring to residential levels of care or IOP or PHP. I say, listen, this does not bind us to taking the bed when it becomes available, but I need a backup plan. And if the wait is 6 weeks, I need you on that list yesterday. So I refer early, and I suggest that we all do that.
And this next question is a little bit of a follow-up of that, but if a therapist is working with an individual with an eating disorder, how do they know when it's time to seek medical care or a higher level of care for the patient? Specific signs, symptoms, thought patterns that are exhibiting?
That's a great question. So not living in the therapy space myself, I think I would say that when you have a concern, it's reasonable. I can't tell you how many times like a family will bring in and they're like, wow, the therapist says she might need to see you. And like the family doesn't even have an idea because all of the behaviors are so secretive and there hasn't yet been any vital sign instability. By that point, I think we've sort of, we're a little bit behind the 8 ball. So if you have any concerns, I think it's reasonable to bring up for at least that visit with the PCP, who can again do some subtle screening in terms of vital sign measurement, lab measurements, but also can just inquire about eating habits. I would say the things that worry me a lot when I think about young people is intensity of exercise. So it's not uncommon for young people to start joining teams, but if what they're describing is that they are having overuse injuries, if they are not able to rest, even though their coaches said, listen, we only have practice 3 days a week, but they are exercising intensely 7 days a week, those are big red flags for me that I think sometimes go unseen. Also, if they are describing any distress around eating opportunities. So if they're like, oh, I couldn't go out to dinner with my friends. I don't know. I just can't ever figure out what to eat, or they're just going to think I eat too much. So if they are not eating with their peers, if they're avoiding social situations because there's food involved, I think those are really big indicators for me that the patient might need further evaluation.
Great. These questions are tying really well into each other. This next question is asking, would you recommend a hospital evaluation or a mental health provider like a CSB evaluation?
That's a great question. So I think it depends a little bit on what you're seeing. There's certainly times where there is enough distress by an eating disorder that I think the mental health route and even a crisis evaluation is indicated. We know that inadequate nutrition can increase suicidality from the Minnesota starvation trial, right? Like, so we know those things can go hand in hand. So I don't think it's ever wrong to go with a CSB. I will say though that I'm a big fan of getting data from vital signs and growth trajectories. I think maybe the pediatrician in me, but that those again expected points, so expected pubertal development, expected growth, expected linear growth and height, all of that stuff is something that a PCP with a long-standing relationship can look for patterns. And so I think that can I choose both? Let's go with both. Both a medical evaluation and a mental health evaluation sound like a good idea.
Yeah, you can do both. Maybe the PCP can provide additional context that really can help direct you towards the correct referral. Which this next question ties into is it typical for insurance to be problematic in covering cost of inpatient treatment for eating disorders? I found this to be very challenging when trying to link clients to resources.
Yes, it can. So for patients with private insurance, there are a lot more options. For patients with public insurance, Medicaid, there are far fewer options. So hospitalization for medical stabilization. So if you have abnormal vital signs or abnormal electrolytes and you get admitted here, like at UVA, that's going to be covered regardless. But the number of programs who provide specific eating disorder care for longer periods of time, either in the inpatient setting or a residential setting that accept Medicaid, are few and far between. I will tell you that we are actively working on that piece of advocacy. So we are working with sort of like our legal aid partners to get letters in writing, because there is mental health parity and eating disorders. Well, there's physical health parity too, where public insurance is supposed to cover those same services. And eating disorders fall through this crack because they need such a specialized combination of both medical monitoring and mental health care that, again, the number of facilities that do this well are few and far between just at baseline for youth. And then if you want to find one that accepts various insurances, it's kind of a nightmare. And so again, we hesitate to give out her name or email address, but like we are again blessed to have a care coordinator who does all of these calls and sends out face sheets and information from insurance. So it's a huge challenge to navigate that process for patients and families. There is one additional resource that looks at funding for eating disorders in Glencore. It's like right out of my mind, but maybe I can email you it later and you can
Yeah,
include it.
sure. And when we follow up with the slides, I can include that as well, and even
Okay.
potentially that NEDA tool that you mentioned.
Yes, I can link to that
We
too.
have one more question here before the end of this presentation, but first, just so all our participants know, I've put in the chat a link to the evaluation, the request for contact hours, and there is a part 2 on September 22nd at 1 p.m. With Dr. Sarah Groff Stevens, who's so kind to join us on her maternity leave to do a presentation. So I'm going to, Dr. Taylor, ask you this final question. And then if you are able to, if you could give a little teaser maybe to part 2 for our audience. So if they are interested, they can register for that as well. So the final question we have here is, do you have any information, a reference tool that outpatient clinicians can use for the family treatment with teens?
Yeah, so there's a couple of books that I think do it in a really digestible format. We've even had families who do it on their own, right? So again, we recognize that there is a dearth of providers who have this certification for the full manualized, and then even just a dearth of patient or providers who are comfortable with managing eating disorders. So there are a couple of books that I think are really, really helpful. And so I will give those to Glencora too. We use the plate by plate method, which is written by 2 registered dietitians, but it walks through like an FBT approach to this, and parents find that extremely helpful. And then there's a smattering of other books like How to Help Your Teen Beat Anorexia. And so I can provide those because I think that, again, we've had several families who have started the process on their own because of lack of access to resources.
Thank you so much. And do you have a little bit, can you tell us a little
Sure,
bit more
stay
about
tuned.
yeah.
Stay
Part
tuned.
2.
Dr. Stevens is a lifesaver because, again, I am not a therapist, but as a PhD level social worker who is exclusively doing eating disorders as her career as a clinician and as a researcher, she comes with a wealth of experience. On the West Coast, she provided care in partial hospitalization programming, and she is just such a thoughtful provider that I hope you all tune in then.
Yes, thank you so much. I really appreciate that. Again, everyone, there is access to the evaluation, a request for contact hours, and registration for part 2. And I will be following up with you all. I am going to share a PDF version of the slides, and as well as put a recording of this presentation on YouTube so you all can access it later for reference or to share with your colleagues. And also follow up with some of the resources that Dr. Taylor has referenced throughout this presentation. And I hope that is helpful for you all. Again, thank you so much. I'm just going to linger here a little bit to give people who are still in the chat a little more time to access the links to the evaluation and the request for contact hours. But the presentation is over, and I hope you all enjoy the rest of your afternoon. Thank you so much, Dr. Taylor.
Thank you, Glencora. Thank you all. I really appreciate the questions. They were very thoughtful. Bye-bye.
Just a heads up, I'm going to remain